Ladies and gentlemen, we will start the session. So let me begin. Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Conference of Silesia 2025. My name is Michał Azierski, and together with Aleksandra Sowa, we have the honor of moderating this session. We would like to explain to you the rules of the session. The order of the presentation will be the same as it is in the abstract book. The maximum time for the presentation is 7 minutes, and it will be counted. For the discussion, you will have 3 minutes. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessments will be verified. We kindly ask the jury to assess the scientific value from 1 to 5, way of presentation, discussion, and own contribution. When the session ends, we kindly ask you to give us the cards and we'll verify them. So I think it's finally time to start with the first presentation, titled microRNAs as non-invasive biomarkers in small cell lung carcinoma, comprehensive review of current literature. I would like to welcome on stage the first author. Please come. Yes, yes.
Hello, everyone.
So do we have in here the author of the work, microRNAs as non-invasive biomarkers in small cell lung carcinoma?
Yes, I'm here.
So, yes. Mamy pracę online? So, can you hear us?
Yes, I can hear you.
Yes, okay. So, I think you can start. You have 7 minutes for the presentation, and we can see your presentation. So, good luck.
Thank you very much. Hello, my name is Michał Bednarz. I'm currently 4th year medical student from Medical University of Lublin, and today I want to present to you the work about microRNAs as non-invasive biomarkers in small cell lung carcinoma. Firstly, what is microRNA? It is full form of short, single-stranded, non-coding RNA, 18 to 25 nucleotides long, and it regulates functions of other genes in terms of protein synthesis, and by over or under expression of microRNA, there could be gene suppression or activation, and in conclusion, starting or stopping the molecular pathway. The lung cancer is secondly most common diagnosed form of cancer from last year worldwide, with over 2.2 million cases diagnosed. About 14% of all lung cancer cases are expected to be small cell lung carcinoma, which is a fast-growing and aggressive subtype of this cancer, and it cannot be treated by surgery. The only treatment options are chemotherapy and radiotherapy, and increasing rates of drug resistance, chemo resistance, and radio resistance makes this cancer hard to treat. And in the next few slides, I will explain the role of microRNA in developing chemo resistance of this subtype of cancer. Our team conducted systematic literature research throughout PubMed and Scopus, and we identified relevant studies exploring microRNA expression in small cell lung carcinoma patients, taking into considerations mainly biopsy samples and small cell lung carcinoma cell lines, and mainly studies mainly utilized QRT PCR method to assess microRNA expression in those cell lines. We found that microRNAs play a critical role in cancer progression and treatment, influencing various biological processes, including immune cell infiltration, cell proliferation, apoptosis, and, as I said, analyzed studies included mainly biopsy samples and small cell lung carcinoma cell lines. Notably, the most specific forms of microRNA in this form of cancer was microRNA 75P, microRNA 335, and microRNA 22-3P. The microRNA 75P was downregulated in small cell lung carcinoma cells and indicated doxorubicin resistance of those cells compared to the parietal cells. And it targets PARP1 gene, and causes its downregulation. So downregulation of this form of microRNA causes upregulation of this gene and induces doxorubicin resistance of small cell lung carcinoma cells. MicroRNA 335 was also downregulated in small cell lung carcinoma cells compared to the parietal cells, and was responsible for multi-drug resistance of those cells by affecting WBP5 gene. Also, downregulation of this microRNA causes upregulation of this gene, and in conclusion, making more cell proliferation, migration, and inhibition of apoptosis, so it promotes cancerogenesis. MicroRNA 22-3P was also downregulated in small cell lung carcinoma cells. Overexpression of this family of microRNAs, so microRNA 22, significantly promoted apoptosis and significantly inhibited the migration and proliferation of small cell lung carcinoma cells, and decreased rates of metastasis of this cancer. It is an image by our co-author Julia Gontarz showing which types of microRNAs are decreased in terms of expression in small cell lung carcinoma cases and increased in expression in small cell lung carcinoma cells. Notably, only one microRNA subtype is overexpressed in those cells, and the rest are decreased. This review shows there is much more room for research in this area and to enhance diagnostic and therapeutic strategies in managing this aggressive cancer type. And there's also more research needed to establish microRNAs as diagnostic and prognostic markers for small cell lung carcinoma, and also to assess the presence of microRNAs and their over or under expression in other bodily fluids more accessible for average physician, such as blood, pleural effusion, to enhance diagnostic and prognostic properties. Thank you for listening. Do you have any questions?
Thank you very much. Do we have any questions from the jury?
First of all, congratulations on your work. Secondly, to be honest, I'm not generally in your area of expertise, but I truly admire your contribution to the studies regarding lung cancer. As far as we're talking about systematic review session, it's a general remark, not only for you. Hopefully, I won't have to make it in the future. On this session, I believe we should assess the methodology of systematic reviews, and it has been described very poorly in your presentation. I mean, you have only said that you, first of all, you said that you only explored PubMed and Scopus, and the general idea of systematic review is to look in as many possible sources as are available in the world. So the more sources you look into, the more your work will be valuable. Second of all, we do not know how many sources have you explored and what was your flow diagram of all the publications you included or excluded. And of course, we didn't have any information about any risk of bias assessment. So generally, for me, I'm very sorry to say, it looks like the way you present it, because you've probably done great work, which will be described in the article, but the way you presented it, it looks like a general review rather than a systematic review, and that's my general opinion, general this is how I feel about this particular presentation. But as I said, while preparing the article, you will include all the things which I will mention. It will have great scientific value. I believe in that. Thank you.
Thank you.
Do we have any other questions? If not, thank you very much for your presentation.
Thank you very much.
Now I would like to invite the next presentation entitled Pedicle Screw Placement for Adolescent Idiopathic Scoliosis by Paweł Łajczak.
Dear audience, dear jury, my name is Paweł Łajczak. I am third-year medicine student from the Faculty of Medical Sciences in Zabrze. And today with my colleagues from General International Research Group, we prepared our very first network meta-analysis concerning the different navigation techniques for adolescent idiopathic scoliosis fixation. Idiopathic scoliosis is a common spinal deformity affecting between 1 to 3 patients in adolescent age. It affects lifestyle and requires proper treatment. Treatment not only involves traditional conservative management with braces, but also a surgical approach, which might involve, for example, posterior approach pedicle screw instrumentation. Various surgical techniques for navigation were implemented. Traditional navigation relies on the freehand navigation based on anatomical landmarks. However, it's relatively inaccurate, and novel technologies such as Mazor self-station navigation or TNAVI robot-assisted surgery were developed to aid spinal surgeons. However, question remains, as it's unclear currently in literature which one of these three methods is the most effective one. This study followed PRISMA and Cochrane guidelines with network meta-analysis extension to prepare a comprehensive synthesis comparing these three techniques. This study was prospectively pre-registered, followed previously mentioned guidelines, and also we searched several databases which allowed us to find eligible studies. Screening was performed by 4 authors due to the large number of studies, and outcomes of interest included pedicle screw accuracy along with clinical outcomes. Robin's tool was used for risk of bias assessment, and certainty of evidence was assessed by grade. The primary outcome was the pedicle screw accuracy, and Gertzbein-Robin scale is presented here. Grade A and grade B together are considered clinically acceptable, while grade D and E are considered as severe screw misplacement. We employed a Bayesian network meta-analysis in R software with GEMTC package to provide a robust meta-analysis in network meta-analysis framework, non-informative priors and random effects model with 100,000 iterations was employed. After a comprehensive search of over 9,000 studies, we finally include 12 studies. These studies account for over 700 patients and 8,000 pedicle screws, and most of the studies compared robotic navigation to freehand. There were no 3-arm studies, so there were no studies directly comparing 3 treatments at once. Here's an example of a network plot for our first outcome, which is the accurate grade A screw placement, so without misplacement. Our synthesis revealed Firstly, no significant difference in terms of direct and indirect evidence. Furthermore, robot surgery showed significantly higher odds for accurate screw placement compared to freehand navigation. This was not noticed in comparison between navigation to freehand or robot to navigation. In terms of severe screw misplacement over 4 mm, we observed that both navigation and robotic surgery were superior to freehand. However, there was no significant difference between robotic and the navigation itself. Also, we found no significant difference between direct and indirect evidence. Interestingly, in the operation time, there was no significant difference between any of these three methods. Here is a summary called SUCRA, which stands for the Summary Under Cumulative Ranking Area, which in short summarizes the best treatment for each arm. As shown below, robotic surgery showed the highest odds for fully accurate screw placement and correction rate. Navigation showed highest odds for clinically acceptable screws, and cup angle along with the lowest odds for severe screw misplacement. On the other hand, freehand surgery showed shortest operation time and blood loss. However, all outcomes besides the aforementioned screw accuracy were insignificant. Robin's assessment revealed moderate concerns in most of the studies, and one study was graded with serious risk of bias, mainly due to confounding. Grade assessment revealed some concerns, and high certainty of evidence was given only in comparison between freehand and robot and freehand and navigation in clinically acceptable screws, and in the comparison in the severe misplaced screws between freehand and navigation. There are several conclusions to summarize this presentation. First of all, the robotic surgery is the most accurate. However, computer-aided navigation of the pedicle screws is sufficiently good among these three methods, as it provided highest odds of clinically acceptable screws. On the other hand, freehand surgery provides shortest operation time and lowest blood loss among the three methods. However, this meta-analysis is limited by relatively small number of studies, small number of comparisons, especially between robotic and navigation surgery, and by quality concerns in the observed studies, as there were no randomized studies. Thank you very much.
Thank you very much. And now I would like to invite jury to ask some questions.
Thank you for excellent work and congratulations. But I have one question, maybe an idea, because these methods used based on generalization, the patients, the doctors, disease, and tools. That when we compare the work of this kind of medicine, the tools, I think it is another kind of things. Because, for instance, if you compare on your Olympic Games, the people who are in different kind of sport, that you have only the humans. If you, for instance, compare the humans with tools, for instance, with Porsche car or another kind of tools, that it is a big difference for comparison these methods. In your presentation, you compare the human working on help the people, help the patients using the navigation system. Navigation system work as we use as an advisor system and we have decision used for use it, and robots that work as a telemanipulator or any kind of devices that help us to prepare these operations better. What is the idea where we can compare all the robots or different kind of robots, all the navigation system or different kind of navigation system, showing this systematical review? What's the criteria for compare all the robots in one part, or all the navigation in one part, where it is possible and where it is important for us.
Thank you very much for your question. Generally speaking, it's expected that these robotic systems and navigation systems will vary. And naturally, they vary because they are from different producers, and even if they are in the same treatment arm, their outcomes might be different, and indeed, some heterogeneity was observed. In our case, because that was a Bayesian meta-analysis, which allows for more conservative approach, the confidence intervals were wider, and it allowed us for more robust comparison to involve this heterogeneity between different models. So we believe that by this Bayesian meta-analysis, the differences in the term of the different robotics models were not as significant as problems in terms of confounding or other aspects itself in the study methodology.
Okay, thank you.
Are there any other questions? Okay, so thank you very much, and I think we can move on to the next presentation.
Ladies and gentlemen, and dear jury, because that we do not have the authors of the presentation number 3 and 4 that are connecting online, we'll jump to the presentation number 5. The presentation, the work titled "The Neuroimmunological Correlates of Depression and Schizophrenia: A Review of Hypotheses." Do we have the connection with the author?
Yes. Do you hear me? Do you see me?
Yes,
now?
We can see you and we can hear you. But we still don't see your presentation. Could you please share your screen with your presentation?
Yes. Do you see my screen now?
Yes, we can see your presentation. Just go full screen and we can start. You have 7 minutes and good luck.
Okay, thank you. Good morning. I am Aleksandra Kozińska, and I would like to present an overview of current hypotheses and recent findings regarding the neuroimmunological mechanisms of depression and schizophrenia. So depressive disorders and schizophrenia are complex psychiatric disorders with multifactorial origins. Their pathogenesis has not yet been fully explained, but historically, the dominant theories have emphasized neurotransmitters imbalances, mainly serotonin in depression and dopamine or glutamate in schizophrenia. However, over the last decade, accumulating evidence has pointed toward the immune system playing a significant role, particularly chronic low-grade neuroinflammation and microglial activation within the brain. And this opens up new potential targets for both understanding and treating these disorders. This review of the literature in English was performed using the PubMed, Scopus, and Web of Sciences databases using the appropriate keywords. The time range of the search articles was set to 2020 to 2025 and included were original articles such as clinical studies, preclinical studies, and interventional trials. Among the most studied, inflammatory markers in psychiatric research are interleukin-6, tumor necrosis factor alpha, and interferon gamma, and C-reactive protein. Recent studies have shown that patients with treatment-resistant depression disorders and those with schizophrenia, especially those with predominant negative symptoms, often present elevated interleukin-6 and C-reactive protein levels. Notably, C-reactive protein levels above 3 mg per liter may help define an inflammatory phenotype of depression, potentially guiding more personalized therapeutic strategies. These cytokines cause neuronal apoptosis, disruption of the blood-brain barrier, enable invasion of immune cells, and in consequence, maintain the inflammation in central nervous system. Turning to neuroimaging findings, positron emission tomography studies using translocal protein ligands have revealed increased microglia activation in key brain areas such as prefrontal cortex, anterior cingulate gyrus, and hippocampus. This activation is often positively correlated with cognitive dysfunction and the severity of negative symptoms. Microglia are crucial for brain homeostasis, but when overactivated, they can contribute to excessive synaptic pruning, possibly explaining the cognitive decline observed in both depression and schizophrenia. At a molecular level, interleukin-6 plays a crucial role by activating the JAK-STAT3 pathway. This promotes the differentiation of pro-inflammatory Th17 cells and suppresses regulatory T cells, taking the immune balance toward inflammation. Moreover, both interleukin-6 and interferon gamma activate indolamine 2,3 deoxygenase, and this shifts tryptophan metabolites away from serotonin production and toward the quinoline pathway, producing metabolic quinolinic acid, which is neurotoxic. This also reduces brain-derived neurotrophic factor expression, impairing neuroplasticity and promoting symptom progression. Recent clinical trials provide strong support for anti-inflammatory strategies. For example, in depression, adding celecoxib to SSRI therapy has shown improved outcomes, especially in patients with elevated C-reactive protein levels. In schizophrenia, minocycline and tocilizumab have demonstrated positive effects on negative symptoms and cognitive performance, particularly in patients with high interleukin-6 levels. Preclinical models are consistent with clinical data. For example, administering interleukin-6 or lipopolysaccharide in rodents induces depression-like behavior. Conversely, blocking interleukin-6 not only elevates symptoms, but also preserves hippocampal brain-derived neurotrophic factor levels and prevents synaptic loss. This highlights its neuroprotective potential. To conclude, there is strong evidence supporting the role of inflammation in both of these diseases. Increased levels of pro-inflammatory cytokines in the central nervous system have been demonstrated in patients with depressive disorders as well as in schizophrenia. By affecting microglia, cytokines can induce neuronal apoptosis, which causes the symptoms of these diseases. Immune cells, especially T lymphocytes, and its imbalance may play a role in the neuroimmunological imbalance. Excessive activity of microglia cells has been found in patients with schizophrenia and depressive disorders, especially in brain areas related to cognitive functions. Disturbances of the blood-brain barrier and activation of microglia may lead to neuroinflammation and central nervous system dysfunction. Interleukin-6 emerges as a key mediator and promising therapeutic target. Future directions should focus on incorporating inflammatory biomarkers like interleukin-6 and C-reactive protein levels into clinical decision making to enable more personalized treatment strategies. And thank you for your attention. I'd be happy to take any questions.
Thank you for your presentation. And before I will give the microphone to the jury, I would like to inform you and all the participants that this session is the session of the systematic review, and the normal reviews are not suitable for this session. So all of you should be informed and well know this information. So now I will give the microphone to the jury.
First of all, congratulations. I believe that looking for multifactorial etiology of depression is very important, and it will have an impact on the treatment of depression as far as pharmacology is concerned. So thank you for your work. As far as my predecessor said, that was the first thing I wanted to say. Before my predecessor said, I had a thought that there should be a separate session regarding reviews, because this is not a systematic review. This was the first thing which I said to the first person who conducted a presentation. In a systematic review, the idea of a systematic review is that you prove that the data you taken into consideration are the accurate ones. You investigate the sources, you find them eligible or not. I didn't find this assessment. As I said, the idea is very valuable and very interesting. I was really taken away by your presentation. It was very good. It was a very good as a review, but sorry for the harsh words. I hope that they will help you improve in the future, so that you can focus and learn. Because it's hard work to learn how to write a proper systematic review, because if you've heard the presentation which was before yours, it was of course a meta-analysis, so it was a bit different. But these works are, as far as methodology are concerned, are uncomparable, absolutely uncomparable. Because there was all the things which I said before, no Prospero, no flow diagram, no risk of bias assessment. Very good idea. Your heart is on the right side, as I say, so keep up the good work, but improve the idea of systematic review, because this has not been one. Thank you very much.
Thank you very much.
Thank you very much. Do we have any other questions? If not, thank you very much for your presentation.
Thank you.
Ladies and gentlemen, I am pleased to invite our next speaker, Natalia Wyroba, in a presentation entitled Fungal Infections of Cerebrospinal Fluid Shunt in Pediatric Patients.
Good morning, everyone. Today I will be presenting a systematic literature review on fungal infections of cerebrospinal fluid shunts in pediatric patients. To start with, hydrocephalus is the most prevalent neurosurgical condition among children, which is caused by the disruption of normal cerebrospinal fluid flow dynamics. Treatment methods differ based on multiple factors. However, our main focus was on cerebrospinal fluid shunting, which is considered to be the gold treatment standard for hydrocephalus, and was the main focus of our study. However, it carries risks of infections, including fungal ones. So our goal was to conduct a systematic review on fungal infections of cerebrospinal fluid shunts in pediatric patients. We structured our work using PICO framework, focusing on children with cerebrospinal fluid shunts, diagnosing and treating of fungal cerebrospinal fluid shunts infections, comparing different treatment strategies on resolution of infection, mortality, and reoccurrence rate. We followed PRISMA guidelines and searched 5 databases, studies published from inception until 6th September 2024. In result, we included 26 studies, and the study protocol was registered with INPLACI. Risk of bias was assessed by the Joanna Briggs Institute Critical Appraisal Tools for case reports and case series, respectively, and 8 of the study had moderate risk of bias, and the rest was low. Our review encompassed 39 patients. 38 of them were from studies we look at, and one case was an institutional case, which in fact was the main catalyst for this review to happen. The majority of patients were younger than 1 year old, and the mean age at diagnosis was 6.27 years. Prominent risk factors were neonatal, like prematurity and low birth weight, and infections, meaning history of prior infection, and use of broad-spectrum antibiotics. 76.92% of all fungal shunt infections was caused by Candida genus, and second most important, most frequent genus was Aspergillus. Other species were responsible for individual cases of infections. Almost 3/4 of the group experienced early fungal infection within first 6 months from shunt implantation, and clinical presentations were non-specific, mainly fever, vomiting, or signs of increased intracranial pressure. Diagnoses were mainly achieved through cerebrospinal fluid cultures, and the most common abnormalities in cerebrospinal fluid analysis were elevated white blood cells count in 86.36% of patients, elevated protein levels in 73.91%, and lowered glucose in almost 70% of the group. The main route of antifungal agent administration was intravenous. However, in cases of persistent fungal infections, despite of intravenous route, intraventricular one was used. The majority of patients was treated with monotherapy, primarily amphotericin B, and the mean time of antifungal therapy across the entire group was 53.3 days, and much longer in the group of patients with reoccurrence, 122 days on average. When it comes to surgical approaches, almost all patients required shunt removal. However, not all of them needed new shunt implantation later on. Almost half of the group needed external ventricular drainage, and in 2 cases, fungal vegetation was removed, including our institutional case. Mortality rate and reoccurrence rate were both 10.81%. What's important, none of reoccurrence cases was fatal one. In conclusions, fungal cerebrospinal fluid shunt infections are rare but serious, especially in the group of neonates and in those with history of prior infections. Most patients experience early fungal infections onset within first 6 months from shunt implantation, and resistance to intravenous drug administration may necessitate intraventricular administration of antifungal drugs. Thank you so much. I welcome any questions.
Pytania mogą być również zadawane po polsku.
Żeby można było ocenić. We have to assess the creative own contribution. Please show your contribution, creative contribution to this work.
Okay.
Please.
To be honest, it was mine and my co-author first systematic review, so I participated in every step of our systematic review. Maybe it wasn't the most sufficient plan, but it is the best way to learn. And of course, I extracted data from studies we selected. I wrote the manuscript and prepared this presentation, of course guided by our supervisors. However, writing, screening, selecting studies was done independently.
Okay, congratulations on the presentation and very good subject for this.
Congratulations. Thank you for a correct methodology. When I listened to you, I felt that it's your first systematic review, but you fill all the blanks. You fill all the boxes like PICO, Prisma, flowchart, risk of bias assessment. I have two questions. How many researchers have assessed the articles? I mean, during the assessment, during the inclusion and exclusion of the articles?
Only two. Me and my co-author, Natalia Cardas.
Okay, but in a situation when you had a problem to decide whether, for example, because if you both said, okay, we include them or we exclude them, it's okay. But in a 50-50 situation when one of you said, I will include it, the one excluded, who was the judge of that?
We didn't have that situation, so we didn't need to find out how to resolve that.
Keep that in mind. In a bigger number of research you will have, so it's good to have a third researcher to work with, especially with the big databases, to be kind of a judge of what should be included, what should be excluded. So when you said about two researchers, it has rung a bell. What have you done in these situations? So in further research, it won't be as nice. So you have to be prepared methodologically to do that. And you might have mentioned that, but I didn't hear it. Which databases have you used for the research?
5 databases, including Prisma, Scopus, Web of Science.
Okay. As I said, it's your first, as you said, it's your first systematic review, so congratulations.
Thank you so much.
Thank you.
Thank you very much.
So thank you very much for your presentation, and we will jump to the next presentation called Exploring Treatment Approaches for Neuromyelitis Optica Spectrum Disorders, and that's the online presentation.
So good morning once again. Do you hear me and do you see me?
Yes, we can hear you and we can see you. Just show us your presentation.
Okay, do you see presentation now?
Give us, yes, we can see your presentation. You can start, you have 7 minutes.
Okay, thank you. So good morning once again. In this review, I want to present the current treatment approaches of neuromyelitis optica spectrum disorders. And for this purpose, we conducted a review of the literature using the online databases such as PubMed, Scopus, and Web of Sciences. We used the appropriate keywords such as neuromyelitis optica spectrum disorders, Devick's syndrome, and biologic therapies. The time range of the search articles was set to 2020 to 2025, and included were original articles. Neuromyelitis optica spectrum disorders are a rare, severe autoimmune disease of the central nervous system. Its key pathogenic mechanism is the presence of aquaporin 4 immunoglobulin G antibodies found in over 80% of patients. Main symptoms of this disease are optic neuritis, where can lead to blindness, and longitudinally extensive transverse myelitis, what often results in paralysis. Diagnosis of this disease is based on detecting aquaporin 4 immunoglobulin G antibodies, magnetic resonance imaging findings, and excluding other central nervous system diseases like multiple sclerosis. During relapses, treatment includes intravenous methylprednisolone pulses, plasmapheresis, particularly effective in seronegative patients, and intravenous immunoglobulin when steroids and plasmapheresis are insufficient. Long-term treatment includes immunosuppression with traditional immunosuppressants such as azathioprine, mycophenolate mofetil, and rituximab. And the other option is modern biologic therapies, which now offer higher efficacy and better safety profile. This biologic treatment includes satralizumab, which reduces inflammation, and aquaporin for immunoglobulin G antibodies production by blocking interleukin-6 receptors. And SAKURA SKY and SAKURA STAR trials have shown relapse reduction by 55 to 62%. It is administered subcutaneously once a month and is the only one biologic drug reimbursed in Poland since 2022 year. Eculizumab, by blocking C5 cleavage, inhibits complement activation. PREVENT trials have shown relapse reduction by 94%. It requires intravenous infusions every 2 weeks and prior meningococcal vaccination. Inebilizumab causes broad B-cell depletion, including plasma cells and their precursors. Its effects are visible as early as 1 week after treatment initiation. It is administered intravenously every 6 months. This table includes comparison of new biologic therapies, and as we can see, satralizumab is only one biologic therapy currently reimbursed in Poland. Eculizumab provides the greatest reduction in relapse frequency, and inebilizumab is characterized by the lowest injection frequency. To conclude, biologic therapies have significantly improved outcomes in neuromyelitis optica spectrum disorders, enabling effective relapse prevention and significantly improving patients' quality of life. Therapy selection should consider anti-aquaporin 4 immunoglobulin G status, disease severity, infection risk, and patients' preferences. Satralizumab is currently the most accessible biologic therapy in Poland because it's the only one of this drug what is reimbursed in Poland. The future of neuromyelitis optica spectrum treatments lies in personalized approaches, combination therapies, and targeting new molecular pathways such as neonatal Fc receptor and vascular endothelial growth factor. There are my references, and thank you for your attention.
Thank you very much for your presentation. Do we have any questions? Yes.
Thank you for your presentations. I want to ask you about this creative contribution, because the second very interesting subject, pure methods, don't worry about this, but how you create this term, how you find this subject for the work. It is interesting for me in these questions.
How I find this topic?
Yes, yes.
A few months ago, I was in the other conference where I present the case report of the patient with neuromyelitis optica spectrum disorders who was treated by satralizumab for a few years, and satralizumab provides her very good outcomes. So, and it was very effective therapy for her. Then I was reading about this drug because I knew what this drug is, but because of effects of what satralizumab had for these patients, I was reading a lot of this drug. I was reading a lot about this disease because, as we know, it's not as popular disease, for example, as multiple sclerosis. So that's why I conducted this review with my friends.
Okay, thank you. And please improve the methodology for presentation of the methods, and all will be very good. Thank you.
Thank you.
So I believe it's a student session. So I believe that we should discuss we should discuss things regarding the way of presenting as well. It's not only about you, but it's a general thing which I see on presentations on this conference, on the conference I was attending a year before in our university. I believe that if a session is in English, and we should all improve English. As I said, it's not directly for you. It's a general thing which we should think about as attendees of these conferences. We have this Eastern European pronunciation of English, which could be understood, which is understood among us. So that's why we understand you perfectly, and we understand all the people who perform. But generally, we should think about the way to present. Another thing which came to my mind as I was listening to all of the students, you want to say as much as you can. You want to give as much data, as much as information. Sometimes it's better to speak slower, to say less, but say it in a tone that people will hopefully remember. So I think that the general way of presenting our ideas is very important. And also a thing which concerns you now exactly is the microphone. When it affects the way you're it affects the way you present. It's good to have a better quality microphone. To this way we could, so that we could feel that you're among us. Because if you're away from the microphone, or if it's poor quality, it's difficult to concentrate on things you present. So I think I'm a small joke, a bit of PR coach. A PR coaching for all the presenters could be useful regarding, first of all, language skills, because we will be, I'm sure that you will be presenting around the world, so you would like to be understood all around the world, all of you, and some presenting skills also themselves, regarding that sometimes the quantity of the information you want to give us does not give the quality of the presentation. Okay?
Okay.
But thank you very much. It's, as I said, it's an amazing experience to listen to you all, and to hopefully to be remembered by you, by giving you some friendly advices. Thank you very much.
Okay, thank you for your valuable guidelines for future.
Thank you very much. Do we have any questions? If not, thank you very much for your presentation.
Our next presentation is entitled Persistent Multi-System Involvement After Pediatric COVID-19. Is the author of the presentation with us? I think not, so we are moving fluently to next presentation, the abscopal effect from a rarely phenomenon to a breakthrough in a cancer therapy.
Good morning, ladies and gentlemen. My name is Adam Kowalski, and I have the honor to present to you the work entitled The Abscopal Effect from a Rare Phenomenon to a Breakthrough in a Cancer Therapy, prepared together with my colleagues Błażej Bielański and Nikodem Świderski. Today I'd like to take you on a brief yet important journey into a phenomenon that was once a biological curiosity but may soon redefine how we approach systemic cancer therapy. The abscopal effect, from a Latin ab scopus, meaning away from the target, describes something once considered a biological curiosity, the regression of tumors outside the radiation field, triggered by local radiotherapy. It was first described in 1953 by a British radiobiologist who noticed this paradoxical phenomenon during radiation experiments. He reported that occasionally distant metastases would shrink or disappear even they were never directly irradiated. At the time, this was seen as anecdotal, almost accidental. Without a clear biological explanation, it didn't enter the mainstream of clinical oncology. For decades, the abscopal effect remained a footnote in radiotherapy textbooks. Interesting, but unreliable. That all changed with the advent of immunotherapy. As immune checkpoint inhibitors like PD-1 or CTLA-4 inhibitors entered clinical use, oncologists began to observe more frequent cases where local radiation seemed to ignite a systemic anti-tumor immune response. Suddenly, this once rare phenomenon moved from the margins of the science to the center of oncological attention. It is now one of the most intensely researched effects in modern oncology, not because it's fully understood, but because of what it promises, a bridge between local treatment and systemic control, a therapeutic synergy that could redefine how we approach metastatic disease. Despite growing interest, the abscopal effect remains rare and unpredictable, which limits its practical application. We still lack reliable biomarkers to predict who will respond, and outcomes vary significantly depending on tumor type and immune status. These challenges highlight the need for more controlled, mechanistic studies. Our systemic review followed PRISMA 27-item checklist and had two goals. First, to map out which treatment combination are most likely to induce the abscopal effect. Second, to assess the safety of these regimens. We used Medline and searched for studies using the term abscopal effect. We included only studies that documented the effect and discussed treatment protocols or side effects. Out of 142 search results, 54 studies fit our criteria. They provided both clinical and safety data relevant to our analysis. Our findings suggest that combining radiation with immunotherapy makes the abscopal effect more likely. But which combinations worked best? Here's what stood out. TLR agonists led to response in 72% of cases, remarkably high. GM-CSF about 27%, often in lung, breast, and glioma cases. PD-1 inhibitors triggered effects in 30% of patients. Overall, the combination regimens were well tolerated. Still, immune-related adverse events like pneumonitis or colitis were occasionally observed, especially with PD-1 inhibitors. The studies we analyzed showed no significant differences in irradiation dose or immunotherapy administration regimen. The effectiveness of the protocols in question depended mainly on the immunotherapy drug used. Determining optimal treatment protocols, as well as discovering the biological mechanism behind the abscopal effect, will be a breakthrough step in oncology. This will enable personalized therapy of metastatic lesions in disseminated tumors, which often pose great challenges to the oncology team. The development of the above-mentioned regimens will also reduce the toxicity of the systemic treatment, which will increase patients' comfort and allow for a smoother treatment process. But the evidence, as of now, is still based largely on a small series and case reports. We need robust, randomized trials to explore the biological underpinnings and fully integrate this effect into therapeutic strategy. Unraveling the mystery of the abscopal effect can also help search for molecular grip points that are key in the mechanism of this process. This may allow the development of biomarkers with which to control the therapeutic process and the patient's anti-tumor response. While the abscopal effect remains rare, its reproducibility, especially in combination treatments, cannot be ignored. The synergy between radiation and immune activation may be the key to unlocking systemic tumor control from a local intervention. Our meta-analysis not only reinforces the biological plausibility of the abscopal effect, but also supports its potential clinical utility in selected tumor types and therapeutic contexts. In closing, let me leave you with this thought. What was once considered a rare miracle may become tomorrow's standard of care if we dare to ask the right questions and, more importantly, pursue the answers. Thank you, and let me introduce my co-author to the discussion.
Are there any questions?
Oh, yeah. I'm very sorry to say, but there were several presentations, but the only two which there were only two which fulfill the criteria of systematic review. I have an idea for the organizers. Can I have you for a word? Because I believe that there are free systematic review sessions on this university. To be honest, I came here also to improve myself because I'm learning. I will learn all my life, and I'm still learning. So I have a huge maybe request, maybe an idea. If people will apply for a systematic review, could you send them a checklist whether they have fulfilled the criteria of a systematic review? Because this way, it won't be a waste of time for all of us. I mean, the jury and also the participants. And I think that these free sessions of systematic reviews will shrink to one, which will be the most fulfilling. First of all, you've checked only in Medline. Have you researched any more than the databases? Or it was only Medline? Because I heard it was only Medline.
Yeah, the only database research was Medline.
Okay. As I said previously, the idea of systematic review is to look in as many sources as possible. And I do not mean only databases. I mean also books. And of course, books are the things which come into print are much later. But generally, our languages, of course, it's also very difficult. We all use English, to be honest. But in theory, like in the idea of a systematic review, we should even look in our languages, but no one does that in practice. So, as I said, you did not convince me in your presentation that this has been a systematic review, because we didn't see a Prisma flow chart, we didn't see the risk of bias assessment. When I was your age, I did the same presentations. Believe me, you do not do anything wrong. In recent years, I simply realized that when you do a review and it does not have a risk of bias assessment, it's useless, because you can take two articles. In one, there will be 10 rats research, and the second one, 10,000. These research won't be comparable, yes? That's why in systematic reviews, we collect only the most worthy data, okay? And this is what we want to teach you in systematic reviews, because systematic reviews are the core for evidence-based medicine, okay? So keep up the good work. Thank you for the presentation. But as I said before, look into the idea of systematic reviews, because as students, you can do the best, the most worthy systematic reviews, and I'm sure of that. And of course, in the future. So keep up the good work. Thank you very much.
Thank you very much. Do we have any other questions? Okay. And I'm using this time that I have. I would like to answer the question that was held. Every year we send all the participants the information how the session of systematic review should look like, how the presentation should look like, and the participants send us the abstracts that must look like this systematic review. Of course, we can't in that moment see exactly the presentation, but in this year we drop out more than the half of the abstracts that were sent to us. So, of course, I understand, because this is the problem of many students' conferences around the world and sessions focused around the systematic review, that people not really understand the definition of systematic review. But we will try our best to improve in the next conferences. Yes, do we have a... Let me just give you a microphone.
First of all, you're doing an amazing job preparing this conference. When I was a student, I was also working on preparing a students' conference, so it's an honor for me to be on the other side and see your great work because I know how it's being done. So do not feel bad that you've done anything wrong, absolutely not. I believe that every scientist should take the responsibility for their own work, but as far as you said, we are your students. You do not have to know everything you're learning, but let's help them learn. Let's help them improve. And while assigning to a systematic review, let's create a checklist which way they will confirm that they fulfill the criteria. And if not, when during the presentation, they will be disqualified for not understanding the idea or dishonesty. I believe it should be done this way. Hopefully, you'll consider that, because 3 sessions. I think those 3 sessions will shrink into one. Believe me. Thank you very much.
Thank you very much. For sure, we will take that into consideration. I will that apply in the next conference. So thank you very much for this advice, and we will continue with the next presentation. The presentation titled Amelonic Melanoma, a diagnostic challenge in the field of dermatology and oncology. I would like to welcome on stage the author of this work. Please come.
Good morning, ladies and gentlemen. My name is Victoria Maluida. I'm the 4th-year pharmacy student of the Medical University of Silesia. And for the past year, I've been conducting a research on the topic of amelanotic melanoma, which is what I would like to talk about today. To begin with, in comparison to the pigmented variants, this type of cancer doesn't exhibit a brown or black color. Due to the lack or little amounts of melanin, it presents as pink, red, or skin-toned lesions, which are varied in shape, size, and classification. It is estimated that among all melanoma cases, about 2 to 20% can be considered amelanotic, though some publications state that it's not even more than 8%. The differences in the statistical data are closely related to the difficulty of its diagnosis. Amelanotic melanoma can be mistakenly recognized not only as various benign lesions, but also other malignant cancers, with some examples given in the presented table. Overall, all of those cases account for an 89% rate of misdiagnosis. The reason why this type of cancer poses such a significant diagnostic challenge is a question which I would like to answer today. This presentation is a part of a larger research for which a wide range of records was identified through 2 search engines. The initial amount was reduced by removing the publications which were duplicated using a free software program. Further exclusion criteria were then applied, including works which were published before the year 2010, articles which were not a free full text, and those which focus solely on the pigmented melanoma or melanoma in general, with little to no information about the amelanotic variants, as well as those which brought no new data relevant to my research. After applying those exclusion criteria, 134 publications were then reviewed, from which 48 were retrieved, covering articles from September 2010 to November 2024. And the keywords which were used in this process include amelanotic melanoma, melanoma, non-pigmented, diagnosis, and dermatoscopy. I would also like to mention that for the sake of this presentation, I may sometimes refer to amelanotic melanoma as AM. The results state that in order to quickly detect and monitor those lesions, we need to consider some of their characteristics. One of the methods that proves to be useful in this regard is the ABCDE method, which involves assessing the lesion in terms of its asymmetry, border, color, diameter, and the way it evolves over time. This technique, however, achieves a rather low, because 64% rate of accuracy in case of amniotic melanoma. So we focus on a more in-depth observation of the lesions. The method which proves to be useful in this regard is dermatoscopy, a technique currently considered a golden standard of melanoma diagnostic process. In case of melanotic lesions, it allows us to observe a milky red color covering about 40% of the lesion surface, as well as short white lines visible across it. Possible residual brown pigmentation due to the fact that about 5% of amniotic melanoma cells can still contain melanin, as well as scar-like depigmentation, and most importantly, vascular morphology patterns. Dotted vessels are considered characteristic for the early stages of this melanoma, while linear prevail in thicker, mostly nodular types. However, in cases with thickness above 2 millimeters, polymorphic, atypical linear variants are most common, including hairpin loops and corkscrew types. I would like to highlight the fact that though those vascular patterns are notably mentioned, some publications state that they should not be contributed to certain lesion thickness. Moreover, even though they may aid in identifying amniotic lesions and their malignancy, they aren't AM specific. The dotted vessels, for example, can be found in Spitz navy, and the linear types in basal cell carcinoma or squamous cell carcinoma. In order to raise the accuracy of dermatoscopy, we can combine it with reflectance confocal microscopy. This method allows for a more detailed analysis of the lesion and its histopathological features, including the epidermal pattern, which can be disarranged or in an atypical honeycomb arrangement, as well as the presence of atypical cells, which can be dendritic, hyporeflective, with a pagetoid spread. Yet again, those characteristics aren't AM specific. The pagetoid spread, just as the name suggests, can indicate the extramammary paget disease, and the honeycomb epidermal pattern can be contributed to, for example, dermatofibroma or cherry angioma. In conclusion, even though the mentioned characteristics may aid in identifying amniotic melanoma, the lack of specific diagnostic criteria leads to an 89% rate of misdiagnosis. Further research on the topic and possibly implying some new techniques in the clinical practice are necessary for raising the probability of its diagnosis, especially at the early stages. I hope I managed to answer the questions stated in my presentation.
Yes, thank you very much for your presentation. Do we have any questions? If yes, we have.
From my experience, I wouldn't use in the future Google Scholar because mostly, I'm very sorry to say that, but maybe I would ask you in another way. Do you know how many of your research were from Google Scholar? Were there any research from the Google Scholar? Because generally Google Scholar gives you a great number of articles, some of them which are not reviewed. And I believe if you focused on our databases, because you've only mentioned PubMed and Google Scholar, if you concentrated on Web of Science, Scopus, as I said, in most cases, when from my experience, I didn't have a situation when Google Scholar, because Google Scholar is like a broader instrument, broader database. So when I removed the duplicates, I even looked it up. I didn't see any articles from the Google Scholar. Google Scholar gives you like the idea that you have so many records, but when you concentrate on the number, it turns out that not a single one. When you look at the more legitimate databases, it turns out that there were no only from the Google Scholar. So maybe I would concentrate on our databases. So generally, I would think about that. Thank you for the Prisma flow chart, and hopefully you will also investigate the idea of risk-based assessment in the futures to take to pick the most important data. Thank you for your presentation. For me, it was chilling. It was very important and very giving great self-aware. So thank you for researching a very, very, very interesting and a very important healthcare topic. Thank you very much for your work, and please continue that. Okay.
Thank you very much.
I'd like to thank you for the subject, because if we think about melanoma, we think about brown on black changes of skin. So it's very important to remember us that not only these changes are important, especially that the early diagnosis is very important in the melanoma. So thank you.
Thank you very much.
I think that the author of the other presentation is already on the stage, so we are just uploading the slides. So we are now moving to presentation number 12, robotic and conventional minimally invasive pedicle screw instrumentation. And after that, we will jump back into presentation number 11 due to some technical problems.
Okay. I'm grateful for being here once again. And again, I prepared another presentation on the instrumentation in the spine with the assistance of my General International Research Group. And in this time, I would like to focus on thoracolumbar injuries. These injuries occur in the thoracic and lumbar spine segments, which often are a consequence of high-energy trauma, for example, fall, crushes, or traffic injuries. Complications are serious, and various surgical techniques were developed. More recently, minimally invasive spine instrumentation surgery was developed in order to reduce the invasiveness, potentially improve patient recovery, and reduce blood loss during the surgery itself. Robotic surgery is also stepping ahead, as it was recently introduced in minimally invasive surgical approach. Robot devices such as ROSA, Mazor, Renaissance are emerging and being increasingly applied into field of spine surgery. However, no systematic review or meta-analysis has so far evaluated traditional fluoroscopy-based minimally invasive surgery to robotic-based approach. We followed Prisma, Cochrane guidelines, and prospectively pre-registered this study in the Prospero database. Search was carried out in several databases with keywords related to the robotic surgery and thoracolumbar injuries, and search was performed from inception to January 2025. Several authors performed screening data extraction, and quality assessment was performed with Robbins. And we also assessed the certainty of evidence with grade 2. Similarly, as in the previous meta-analysis, Gertzbain-Robbins scale was used to assess the pedicle screw accuracy. Grades A and B are considered clinically acceptable. Meta-analysis was performed in RStudio with random effects model. Validity of the findings was verified in the trial sequential analysis. After a comprehensive search, 10 studies were involved in the meta-analysis. Most of them, because over 9, were from China. Robotics models involved Mazor, T-Robot, Tianji, Tinavi, and even custom robotic systems. We included a total of 3,000 screws and more than 500 patients. The screw accuracy was significantly improved in terms of fully accurate screws without misplacement and in terms of clinically acceptable screws. However, in both cases, significant heterogeneity was observed. Interestingly, no publication bias was observed, and this was verified with Egger test, which also showed no significant evidence of publication bias. In terms of severely misplaced screws, we observed a significantly reduced incidence of both screws misplaced over 4 millimeters and extremely misplaced screws considered as grade E with over misplacement over 6 millimeters. Did the accuracy significantly improve clinical complications? No, it did not, as the screw loosening rate, incidence of nerve injury, or even infection rate remained comparable, and there were no significant differences. Moreover, no significant differences were found in operation time, confirming that robotic surgery is as effective and rapid as conventional method. Significantly lower blood loss was observed with the use of robotic surgery compared to conventional fluoroscopy-based minimally invasive approach. Moreover, reduced fluoroscopy was observed with robotic surgery, suggesting that radiation exposure is lowered for the surgeon, potentially improving ergonomics by reducing the lesser need for lead aprons, along with reduce the risk of potential neoplasm development. Then length of hospitalization and pain change was comparable in both minimally invasive groups. However, robotic surgery was significantly more expensive. The trial sequential analysis, which was carried, confirmed these findings and showed that accuracy of pedicle screws, fluoroscopy use, and hospital expenses were at true positive results. Quality assessment revealed some concerns, especially in the confounding, measurement of outcomes, or selection of the participants. Finally, grade assessment revealed rather low or very low certainty and outcomes such as operation time or blood loss, mainly due to high heterogeneity in the outcomes. On the other hand, outcomes such as severe screw misplacement or extreme screw misplacement were graded with high certainty. The conclusions are as follows. Robotic surgery significantly improves the pedicle screw accuracy in the thoracolumbar fracture surgery. However, this does not directly translate into reduced number of complications. Fluoroscopy and blood loss are reduced. However, this is at the cost of higher expenses of the surgery. This meta-analysis is limited by the fact that most of these studies, because over 9 from 10, were from China. Along high heterogeneity was observed in the analysis, and there were no randomized trials, and the synthesis is mostly based on retrospective studies. Additionally, outcomes such as cost effectiveness were very limited due to small number of studies which reported this outcome because only 3. Thank you very much.
Thank you, and I would like to invite to ask some questions.
Okay, thank you for the next excellent work. I had to ask you about your knowledge about this robot used for this comparison, because you showed that about 4 or 5 kind of robot was used. But especially, do you know about this robot that during this planning this operation they use the artificial intelligence? No.
They did not report artificial intelligence application in none of the studies. There was one custom robot, but I don't think they directly provided sufficient information about artificial intelligence application in it. It was from China robot.
Okay, thank you. But what is what do you think about this artificial intelligence, if we will use it in robots, will improve the results or no?
In my opinion, this is a very interesting fact, because artificial intelligence is indeed emerging in 2 fields, including spine surgery. I believe it would significantly aid the orthopedic or neurosurgical surgeons, and it would even more potentially enhance these outcomes for the patients. However, I think that we need to wait for bigger trials to verify this. But I think that future looks promising for the artificial intelligence in robot-assisted surgery.
Yes, because 2 years ago we have the Maser robot in our plane for test, and they promote the use of this Maser robot from Medtronic, saying that they use artificial intelligence during the planning, etc. That I think that will be the most important factor in the future. But thank you for interesting presentation.
The thing I want to emphasize and congratulate you on is the international cooperation factor. Thank you very much. Can you tell me, how did this cooperation start? How did you come into this cooperation?
It's funny, because we started as a group of 2 people on the LinkedIn. Then a neurosurgeon joined us. He invited his colleagues from Brazil, and we started growing our group. Currently, we are authors of more than 15 meta-analyses published in impact factor journals. So the collaboration is growing rapidly.
Great, great. Congratulations. It's very inspiring. I'm speechless. Simply, congratulations. Pursue your goal, pursue your topics. All the best for the future.
Thank you very much.
Thank you very much.
I would like to invite to the stage the author of the last presentation of our session. It is entitled Pharmacotherapeutic Aspects of Nanoparticle-Based Systems Used in Drug Delivery Across the Blood-Brain Barrier.
Ladies and gentlemen, jury, good morning. My name is Joanna Michoń, and I'm a 4th-year pharmacy student at the Medical University of Silesia. Today I'll be presenting my work titled Pharmacotherapeutic Aspects of Nanoparticle-Based Pharmacotherapeutic Aspects of Nanoparticle-Based Systems Used in Drug Delivery Across the Blood-Brain Barrier. I'm sorry for the technical issue, and now I invite you to listen to my presentation. The aim of the study was to highlight the challenges of drug delivery across the blood-brain barrier and to explore the potential of nanoparticle-based systems used in neurological treatment. After screening the literature from 2 search engines, 56 articles were selected and reviewed, and 9 of those were selected for the purpose of this work. Based on exclusion criteria such as full text availability, recency, as you can see, it was just last 10 years, relevance to the topic, and alignment with the research question. The keywords used in this study included nanoparticles, nano-based medicine, drug delivery, and blood-brain barrier. It is also worth mentioning that nanoparticles are widely used in other fields than medicine and pharmacy, and that's why the amount of screened literature was automatically narrowed after the identification process itself, because we decided to remove all of the articles that weren't connected to medicine and pharmacy, of course. We then used a software program to delete the duplicates, and then we applied the exclusion criteria that I have mentioned before. And the results were given as shown on the Prisma flow diagram. To avoid confusion, I'd also like to mention that later in my presentation, I'll be referring to the blood-brain barrier as the BBB, to the central nervous system as the CNS, and to nanoparticles as NPs. Overall, it is estimated that about 1 in 3 people suffer from some kind of neurological disorder, by severely affecting over 276 million people worldwide. Neurological disorders rank high in disability-adjusted life years, which combines both years of life lost due to early death and years of life with disability due to illness or injury. Being responsible for over 16% of deaths, they are the second leading cause of death after cancer. The challenge of crossing the BBB was first noted in 1914 with the drug called salvastran, which was used for syphilis. It did not cross said barrier, and then it turned out that over 98% of macromolecules cannot cross the blood-brain barrier, which might be sometimes beneficial in reducing toxicity, but it also limits the options for neurological diseases. This graph displayed on the screen shows the various CNS drug delivery approaches. Most of them do not penetrate the BBB, making nanoparticles, as you can see, a compelling alternative. Nanoparticles, polymeric, lipid-based, or metallic, are range in size from 1 to 1,000 nanometers. Their small size and the loading capacity and also the efficient shape allow them to travel across the blood-brain barrier freely and make them ideal for the CNS delivery. Here on the screen you can see 3 types of nanoparticles that can be used in neurological treatments, like for example a nanomycel, a liposome, and a dendrimer. The next slide presents a comparison of selected types. So this chart compares nanoparticles used in treating conditions like stroke, Parkinson's, Alzheimer's disease, ADHD, dementia, or even brain tumors. Different types of nanoparticles act via different mechanisms, and as you can see, they can potentially be used in a wide variety of disorders, but as for this moment, there's only one drug approved by the FDA, but I will talk about this later in my presentation. The remaining types of nanoparticles mentioned are either still under research, which is mostly conducted on animal models, or they are still in clinical trials. So as I said, macromolecules cannot penetrate the BBB, which consists of endothelial cells, pericytes, astrocytes, and basement membrane. Together, they build a neurovascular unit, so the BBB can protect the brain from toxins, maintaining brain health. So this diagram shows how small substances, just like nanoparticles, can actually penetrate the BBB via, for example, paracellular transport or transcellular transport, with the use of a transport protein by an efflux transport, also 2 types of transcytosis, or by a carrier-based transport. So nanoparticles, apart from the obvious advantages that I have mentioned before, have several more of them. For example, they can target hard-to-reach brain areas. They can safely deliver cytotoxic drugs to their targets, or enable treatment of conditions that are currently considered incurable just because of the BBB limitations. So the conclusions were that the VBB is a major obstacle for drug delivery in neurological treatment. Nanoparticles offer a promising solution thanks to their size and thanks to their versatility. There are many types of NPs that are currently under research or in clinical trials when it comes to neurological treatment. One practical example, as I mentioned, is the drug called Onpattro, which is a lipid nanoparticle-based drug approved by the FDA in August 2018 for treating polyneuropathy in adults in a rare genetic disorder. From here, I would like to sincerely thank my work tutors, Professor Artur Beberok and Professor Dorota Wrześniok, for their guidance, support, and encouragement in preparing this review and allowing me to be a part of a student research group. I'd also like to thank my co-author, who helped me with collecting the data and checking the information. The sources we were not sure about were discussed with our work tutors. Again, my name is Joanna Michoń, and this was my presentation on pharmacotherapeutic aspects of nanoparticle-based systems used in drug delivery across the blood-brain barrier. Thank you for your attention.
Thank you very much. Are there any questions?
Thank you for a fine presentation. We prepared this kind of specific analysis of the literature from the two goals. So one goal, it is for instance, you are a doctor and you try to find the best method for treat the patients. Next, it is for scientists. You are from what is your goal? Maybe you want to prepare for new nanoparticles, new kind of medicines. From these two kind of applications, such systematic review, what is for you the best? Now, the goal, it is as a doctor or as a scientist who try to prepare new kind of the methods?
For me, it is as for the scientist, of course. As I mentioned, I'm a pharmacy student, so of course it's about the science for me.
Okay. Do you have any kind of experience now about this? You tried to use this any kind of nanoparticles for something?
Actually, yes. This is a part of a bigger project that has been going on since last year. Me and my co-author prepared 3 presentations on nanoparticles, not in neurology. It was about nanoparticles used in ophthalmology, but I'm interested in nanoparticles since probably 2022, so it's been going on for a few years now.
Okay, thank you. Congratulations.
Thank you very much.
Congratulations on the best English so far.
Thank you so much.
It's a very valuable input. The way you present, the way you speak, how you present, that's very worthy. So congratulations from my behalf.
Thank you so much. I really appreciate that. Thank you.
Thank you very much.
So, ladies and gentlemen, with that presentation, we came to the end of our session. Thank you very much for your participation in that session. And few words that I have to say, and thanks the jury for your opinions, for your words, for your advices for our participants, and for your guides, for your knowledge that you shared with us. Few other organization information. Would like to invite you for the opening ceremony that will be held in here at 1 p.m. and the decoration and closing ceremony that will be on Friday at 5 p.m. exactly in this A3 hall. And at the end, I would like to welcome to join the After Sync party at DSO Club at 9 p.m. The more information you can find on the Facebook event Carlos from SIMC 2025. And at the end of the end, thank you all of you for being here. Thank you Ola for moderating this session. Thank you once again the jury for your words and for your opinions. And thank you all of you for being here and for sharing your presentation with us. And I think this session is over. Thank you very much.